Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello, everyone, and welcome to another special COVID-19 edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson and your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, and our goal is to spark conversation, ideas, and action. Since we're live, I want to remind everyone about how to ask questions of the presenters. Please type your questions into the question box at any time during the presentation. We'll check periodically for questions partway through and at the end of the session. But you need not wait to ask them. Just type in your questions as you think of them. We're delighted to welcome another Children's Healthcare Canada member, CHEO, to bring you this exciting webinar about their new Pediatric Virtual Emergency Department established during COVID. For those of you on Twitter, please tag us at ChildHealthCan and at CHEO on any webinar-related tweets and share away. And now I'd like to introduce our speakers. Dr. Sarah Reid is a clinical investigator at CHEO's Research Institute and an associate professor in the Department of Pediatrics and Emergency Medicine at the University of Ottawa. Alicia O'Brien is a parent partner at CHEO, and Dr. Sandy T is a clinical investigator at the CHEO Research Institute, Associate Medical Director for Division of Emergency Medicine at CHEO, and Assistant Professor at the Department of Pediatrics and Emergency Medicine at the University of Ottawa. And it's my pleasure to pass the mic to Sarah.
Thank you so much, Paula. We are delighted to be here today to share with everyone our story around our new innovative virtual pediatric emergency department. And as Paula mentioned, I'll stop midway in case there are any questions that we can address at that time. And we have lots of time at the end as well that we can have further discussion. So to start things off, it's always really important for us to frame our conversation around what it's like to have a child who's acutely ill or injured, especially at this time during the COVID pandemic. And so I'm going to invite Alicia O'Brien, who was one of our very earliest parents in the virtual ED with her daughter Sophie, to share her story.
Hi Sarah, hello everybody. Thanks for having me here today. So a couple of weeks, months ago, I don't know, all these days today they seem to be blending together, but it was chaotic in my house, as it remains today. My youngest child was running around, mucking around upstairs with my other child, and literally, 3 seconds after I had just yelled at them to stop what they were doing, my daughter tripped, my youngest daughter. She tripped and nailed her cheek on the corner of my bed frame, and almost instantaneously, the biggest bump I've ever seen on my 3 children popped off her head. And I panicked. I thought I could hold myself together, but clearly I have some improvement to do and didn't know what to do. My husband was on a conference call, couldn't help me. And I jumped onto social media with that awful photo that I actually can't even look at, with a please help me, what can I do, because I don't want to go to CHEO. Now, if you're like me and you have kids, whenever I let them outside after March, it was with the veto of, if you fall, we're not going to CHEO. It's just somewhere where I didn't want to go. We've got ill family members, and I've been managing our COVID exposure best we can. And, you know, the idea of having to go in an emergency room was frightening. So I took this photo, and with one hand, with my hand on an ice pack for her, I got on a local Facebook group and said, "Help! What do I do?" And I was flooded with texts, with responses, many of which were not helpful, as you can imagine. But I was really surprised at the fact, learning very quickly about CHEO's new virtual pediatric emergency. I managed to, quickly look into it, and I'll talk about my experience with that later. But needless to say, I had a pretty terrific experience. So that's why I'm here today.
Thank you very much, Alicia. I think you painted an amazing picture. All of us who are parents on the call, I think, can appreciate that horrific sinking feeling we get when our children get injured, and your picture really does paint a story for all of us. So if we just step back for a few minutes, if we think back to March, mid-March, late March, what were we worried about? We were in the hospital, we were very worried about PPE, personal protective equipment, N95 masks, how the supply was there going to be enough? When were we going to be wearing the equipment? How were we going to use and conserve those supplies? We were also really worried about potential influx of sick COVID patients, and how were we going to manage if we had children coming in who were COVID positive and had significant respiratory illnesses like asthma, bronchiolitis, croup, respiratory distress. We were working very hard, so lots and lots of meetings around how to resuscitate in the COVID era, how to protect the team, the patient, the family during a resuscitation effort. And then I think healthcare providers were also feeling pretty concerned about our own children, our own families, how we were going to decontaminate ourselves after our shifts, potentially having to quarantine ourselves if we ourselves got ill or were exposed. And so there were lots of things, and I think if anyone on the call is a healthcare provider or works in the hospital, you know these feelings that we were having. But one thing that we didn't anticipate is that we were also needed to be worried about the patients that we weren't seeing. So this is a photograph of our ambulatory zone waiting room, which is almost all the time full of patients. And what we didn't anticipate is that this is what that room looks like a lot of the time now. You know, we know when we think back to the SARS crisis in 2002, 2003, that we did see a decrease in emergency visits at that time, and it did last for several months afterwards. But I don't think any of us could have anticipated the significant impact on emergency care during COVID. So just for a little bit of background, the CHEO Emergency Department is one of the busiest in Canada. We see 75,000 visits per year. And overcrowding has been a serious issue in Canadian emergency departments, and pediatric emergency departments are no different. Over the last 15 years, we've seen a really significant increase in use of the emergency department for lots of different problems, and many are low acuity problems. So it's a little bit different than adult emerge, where you run into the overcrowding because there's a lot of admitted patients that remain in the emergency department because there's no beds available upstairs. In the pediatric side, the low acuity volume is one of the big drivers of overcrowding. So just to give you a little bit more sense of what was happening locally, this is a bar chart that talks about our monthly visits over the past 5 years, with number of visits on your y-axis and months of the year along the x-axis. So if we go all the way to the right, the last bar, the pale purple bar, shows that we had a very busy December in 2019. And probably anyone who works in a children's hospital will know from this year that we had an early flu season and a pretty tough flu season. So December was very busy. If we move over all the way to the left, the dark purple bar is now 2020. So you can see January and February were a little bit less busy than previous years. And then in March, April, and May, you can see very profoundly the impact of COVID. So almost a little bit over half the number of visits we normally see in March, far less in April, with a little bit of a recovery in May. And so, I think that visual says it all in terms of what was happening in the emergency department. So if we look by month, if we look in April 2020, this line graph shows a comparison between 2020, which is the lower line, and 2019, the upper line, for daily visits. So along your x-axis, that's the days of the month with a number of visits on the y-axis. And we can just see that normally we would be seeing well over 200 patients a day in April, and we were seeing between 60 and 80 this year. Likewise, in May, we've had a little bit of a recovery, a little bit of an increase back up into sort of around the 100 per day mark. But as you can see, it's still very decreased from seasonal norms. So we started to worry about that empty waiting room, and we really started to worry about where were our patients. You know, I think we can think of, you have a lockdown of society, we have children who are not going to daycare, they're not going to school, so they're not being exposed to those viruses that normally really drive a lot of pediatric emergency department volume. They're not doing their sports or their recreational activity. They're not even outside much, given the weather, and thus we really, you know, it's not unexpected that we're going to see a decrease in injuries as well. But if you work in a pediatric emergency department, you know that almost every day we are making serious diagnoses apart from viral illness and injury. And we really started to worry about where those patients were. We had some local information from different services saying, gee, we're not really seeing the normal illnesses that we regularly diagnose. And we even know that in Italy, there's a series of patients, a paper that was published in May in Lancet Child and Adolescent Health by Lazzarini and colleagues that looked at a review of appendicitis presentations and really found like they had a number of patients that had presented late and thus had significant morbidity associated with that late presentation of that surgical emergency. And you know, we were really worried that that was happening locally as well. We reached out to our networks throughout Canada, North America, Australia, the UK, and this was a universal phenomenon that pediatric emergency departments globally saw a profound decrease in the number of patients who were seeking care. And so we knew that the provincial government was starting to encourage virtual care and telemedicine with both policy and then funding. And we decided as a group that we wanted to leverage the virtual visits that were already occurring at CHEO in our ambulatory clinics during the pandemic to create another option for care for families in our region to make sure that there were no children that were falling through the cracks and that every family had access to care. We wanted to really ensure that with acute health concerns that we could continue to offer high quality pediatric care during the COVID pandemic. And so this is when we embarked on our journey to create the Virtual Pediatric Emergency Department, or V-PED. And we really should do a major shout out to our information systems team at CHEO, who were so nimble, so engaged, and provided so much support in order to make this a reality. So I'm just going to walk you through a few screenshots and just describe to you what, from a patient parent perspective, how they sort of get into this system. And then we'll pass it over to Sandy C, who will walk us through a little bit more the nuts and bolts from the physician side. So when we started to create this new model of care, we had to sort of reimagine emerge. So how do we walk the parent through all of these steps that are normally really standard of care in an emergency department environment? The first thing that we really needed to stress to families was they really needed to make sure that they knew what their primary care physician was offering, because we knew that many primary care physicians and pediatricians had adopted telemedicine and virtual care in their own environment. And we really wanted to ensure that the community was seeking care where it was appropriate, and knowing that many primary care physicians were wanting their patients to be aware of their services and to be able to access as well. But for those patients who don't have a primary care physician or who were unable to access care during this time, we wanted them to start by assessing whether virtual care is right for their child. So we designed this landing page within the CHEO website that essentially walks the caregiver through a number of questions to decide if virtual care is an appropriate option for the problem that their child has on that day. And so we walk the family through a number of questions that basically identifies, do you have a high acuity complaint that really needs to be seen in the bricks and mortar emerge? Or are you a patient who really there's a good chance that this problem could be dealt with through virtual care? And so things like, for example, fever in a young infant, fever in a baby under 3 months of age, really that child needs an in-person assessment because they most likely will have to have some investigations done. A child with significant work of breathing, for example, a child who has an injury where they're not using the injured limb, there's swelling, there's deformity. Of course, those children really just need to be seen as usual in the bricks and mortar emerge. But if you go through all of these questions and you've answered no to all of them, then virtual care is a great option for you. And so once we've gone through that sort of self-assessment, then the parent is asked to fill out a triage form, which provides all of the demographic information that is required to create a visit and to register the patient, and to provide information for the physician in terms of what the chief complaint is. And this is what that intake or triage form looks like. It's within my chart within EPIC, which is the health record that we use at CHEO. And here's a screenshot. It just basically walks them through their demographic information and allows the registration clerk to actually create a visit for them. And then it goes through even things that would be asked by a triage nurse, because of course in this model we don't have the traditional triage assessment, and so the parent actually does that themselves. So what is the chief complaint? What is the child's past medical history, the medications and allergies, immunization status? And we even ask parents to weigh their child in case a prescription is necessary over the course of the visit. This form is then sent to a registration clerk who is working in the department, and the registration clerk contacts the family within half an hour, and that's a service that's offered between 7:30 and 11:30 p.m. with the registration clerk contacting the family. Then they book the next available appointment. And currently, we offer 2 6-hour shifts of physicians doing virtual care, 30-minute appointments. And so we're seeing 22 appointments per day. We are still in a proof of concept or pilot phase. I think that's completed now, but that's the offering that we have at this time. So I think, Paula, I'll pause it there and just see if there are any questions at this point. And then we'll go on to Sandy, and she'll go into a little bit more detail about how virtual care works.
Thanks, Sarah. There are no questions in the question box at this time, but it gives me an opportunity to just remind our audience to type away as you think of the questions, and we'll pose the rest at the end.
Okay, great. So I'll just hand it over to Sandy.
Hi, everybody. Thanks, Sarah. So I'm just going to walk you through our platform a little bit from the medical side. So as Sarah has said, the registration clerk calls the family, they verify the contact information, and then the family is sent an email with instructions on how to log on. It has a clickable link, which makes it quite easy for the families to join the video platform. And just like any other appointment-based visit, families are asked to arrive on the video call about 5 minutes prior to the appointment to wait for the doctor. This is a visual of our EMR. It is on a schedule-based system, but most clinic schedules are pre-booked. So just like in office, you know what the patients are going to be, when they're going to come, when you schedule appointments a week in advance. For us, we are working in an environment where the patients are registering, or the parents are registering in the moment to ask for the appointment. And so we actually had to work quite hard with our IAS team to ensure that this model was modified to fit what we were offering. The physician then is able to access the patient chart directly from that schedule, and the video link is embedded into the patient chart. So we were fortunate enough to have our ambulatory clinics pilot a Zoom for Healthcare secure platform just prior to when the pandemic hit. So as soon as the pandemic hit and everybody was converting to virtual care, we were able to access that programming and use it for our platform as well. The advantage of having this video link within the patient chart is that the physician can then also see if there's any other medical information for that patient if they've ever had a CHEO visit before. The integration of our virtual care platform included trying to mimic what our usual emergency chart looked like. So there's an area for the physician to write their notes. There's a programming to allow us to write discharge instructions and email them directly back to the parent. So whatever is discussed, the parents will have a written confirmation of what that means. We do track our prescription rate, what is prescribed, and it is embedded into the patient chart as well as a communication module to ensure that our family physicians have a direct communication back that their patient was seen on virtual care, and these were the decisions that were made. In virtual care, our doctors can see the parent and the child on the screen and speak to them face-to-face. As experienced emergency physicians, we do make assessments on how sick a child looks, how they're behaving, and even we're able to do some modified examination maneuvers with the help of the parent. So for instance, in Sophie's case, there was a history of a head injury with a lump. We're able to see the injury on the video, assess how tender it is with help from mom, watch how she's moving around, assess her level of alertness, and maybe even ask her to do a few things, like show me your toy, tell me what color it is, can you point at mommy's nose? And that really helps us to formulate a fairly good neurologic exam. Thinking about how we do assessments on video has been challenging for many of us, but surprisingly, most of us has found a way to use our imagination to be able to complete a lot of the examinations without actually having to touch the patient. However, we do know that some exams are not possible, and so there's definitely a lot more shared decision-making with parents, especially when it's not obvious as to what's going on. Sarah, the next slide.
Yep.
The conversation there then helps us to communicate to families when they do need to go to CHEO for an in-person assessment. This is an important part of our model, as we know that a complete physical exam, plus or minus x-rays or lab testing, may be required to make a formal diagnosis and provide appropriate treatment. So through the EMR, we're able to communicate with the ED team. They see our note, they understand our concerns. We're actually able to order certain tests to be completed by nursing even before the doctor sees the patient. For example, we can ask the nurse to collect a urine sample or send them for x-rays. In this way, the family's visit is actually facilitated, and hopefully it'll minimize their time in the emergency department. We've decided that for some minor issues, the nurse can also complete some orders and then send the patient home with the idea that the virtual care physician then follows up the result and communicates back to the family. You can understand from Alicia that we know that the need for reassurance about going to the hospital is fairly significant. And we hear that from a lot of other families too, that they're worried about where the disease is, both in the community, but mostly in the hospitals. Our families have shown that they appreciate knowing why they're going, what will be happening, and that CHEO is taking all the precautions with PPE and distancing to try to keep everyone safe. We also communicate to them that only one family member is allowed to accompany the child. Building this has taken a village. So as Sarah said, big shout out to our information services team who spent many hours of their expertise to get us to where we are today. Our registration and communications team are an integral part of creating a service for families that was easy to find and easy to use. Our mental health team at CHEO was also keen to get involved. We know that isolation, no school, no sports, no social gatherings has been a significant stressor to the youth in our community. And our mental health team offered up crisis workers and psychiatric nurses to join us on any calls on our virtual care platform that involved mental health issues. They also improved our access to mental health urgent care appointments and to the on-call psychiatrists. So we were very fortunate to have engagement of so many individuals and teams within our organization to make this happen. Change is hard. Initially, not being able to see our patients, knowing what was happening in the community was hard, but seeing patients virtually is equally as difficult and not something that as an emergency doctor we've been ever trained to do. So many people in our group, many doctors in our group, were anxious about adding this to our regular workday and whether they could actually do what the platform promised us. So when we started this process, we asked for a lot of feedback daily, every shift from each of the physicians. We learned from them what was working and what didn't. And we really tried to put a lot of effort to put in the changes that were needed to make it function well. Some initial issues that were identified, including how do we staff it? How do we balance between the bricks and mortar emergency and the virtual care? And how do we continue to encourage families to contact their family doctor as their first step for seeking care for their children? Updates were provided weekly to the group, and we continue to keep an open line of communication to troubleshoot any issues. For quality assurance, in the first 2 weeks, we were able to get a couple of our nurses to spend time calling each of our families to follow up, ask them about their experience, answer any further questions about the medical problem as needed, and even call them back to hospital if issues were identified. We heard then that the parents were very excited about what we were offering, and many of them hoped that we would continue to do so after the pandemic. Now we've embedded a digital survey, and it's in the discharge email that is sent to the parent. We've encouraged the parents to complete this, to tell us about their experience, and to give us an idea about what we needed to do to improve the service. So what do we know? We know that on the virtual platform, we're seeing similar chief complaints as would walk into our emergency department. And that includes complaints about fever, abdominal pain, injuries, and rash. About 22% of the patients seen on virtual care are referred into the ED for testing or an in-person assessment. And of all patients seen on virtual care, less than 1% of patients are actually admitted to hospital in the end. To our surprise, 12% of Ontario families using our platform live a fair distance from Ottawa, and 14% of patients live in our neighboring Quebec, both in Gatineau as well as the townships farther away. We hear comments from those families about their appreciation that they weren't having to drive all the way in and spend time waiting. From our surveys, and so right now we have 51 surveys completed on the digital platform. We know that 51% of our families tried to contact their family doctor first, and 69% would say that they would have come to emergency for an assessment if they had not had virtual care as an option. All the families who provided a response thought the technology worked well and would use the service again. And honestly, many families were just really happy to be able to see a doctor, have their questions answered, and not have to leave their home to do it. I think I'm going to let you, I'm going to let Alicia speak again to her experience and what it meant for her. Alicia?
Thanks, Andy. So I can just walk through the steps that I took and how it felt. And I'll tell you right now that I am an absolute advocate of this program, and I will definitely be using it again. So as I mentioned before, I was sitting there with one hand, and I was able to click on a link and register and go through the registration, I guess, which in retrospect was actually the triage, very swiftly. There was a series of questions, and within about 10-15 minutes, I received a phone call. At which I was notified that there would be an appointment for me within the next hour and a half. and just immediately like the sense of relief that I didn't have to go in. So it was safe. It was convenient. I didn't have to leave my house, let alone move this crying child from my lap and get her into the car. But also that I could do it from the convenience of my laptop. I received an email a little bit later with a link to begin my video visit. It was really clear. I clicked a button, and fortunately I did have Zoom already installed on my computer, but it was really clear, all the directions with for anybody that wasn't familiar with Zoom, on how to set that up. So at 6:30, I sat down with my daughter on my knee and clicked the button, and lo and behold, the doctor was even there waiting for me. And that was mind-blowing. Just, from your experiences of going to CHEO, how often is somebody actually ready to see you right then and there? But here I was, and he was there with a smile, and so was I, because my daughter was actually doing better. So she was, playing, and he asked me lots of questions, and put Sophie on camera, and you could visibly see that the egg had gone down. He conducted asked me a couple of questions and asked her a couple of questions, not that she had much interest at all in answering them other than playing with her toy at the time. But I must say, like, the feeling of reassurance that I got from this doctor was such a relief, considering the stress that we were already all under at the time with COVID. It was, and just the convenience. So the visit ended, and very, very quickly I received an email with follow-up instructions. There were lots of questions and answers in that document, questions that I hadn't even thought of asking, but of course I would have had later. Instructions for dosage of medication should I have needed it, and some signs to of what to look for in the event that maybe I should, if things were to change and I should bring her into CHEO. About 10 days later, I received a follow-up phone call from the nurse, which was fantastic too, just to make sure everything had gone smoothly and to ask for feedback. And I thought that was a nice touch to tie everything up. So all up, I wasn't sure how this was going to proceed. I wasn't sure it was the right thing to do. I knew that I needed to be seen. My family doctor was not available, and this experience, honestly, like it couldn't have been better. And I really, really hope that this, not only does CHEO continue to do this, but that this type of medical interaction could be expanded to other practitioners. The convenience is just too good now. So thank you. That's it.
Thank you very much, Alicia. So I think, when we think about what post-pandemic, I think we're still in it now, and we're going to be peri-pandemic for a while. But the question is, what does the future hold? And as I mentioned at the beginning of our session together, that pediatric emergency departments across Canada have been facing issues around overcrowding. And virtual care may be one of those innovations that can help families to get access to care acutely without having to travel to the emerge, and potentially decrease that overcrowding within the emergency room, both for the good of the family, but also to avoid exposure to illnesses in emerge, the impact on families in terms of missing work, paying for parking, all of those things that are important. And it may thus help us to provide more timely care and decrease wait times within the physical emergency department. It's interesting that just last week on June the 19th, the CMAJ News ran an article entitled "Pandemic Advances Alternatives to Hallway Medicine." And there really does seem a bit of a sea change around mobilizing some of these new technologies in order to address some of the major systemic issues that we've been dealing with, particularly in emergency medicine, and that's adult and pediatric alike. We have had lots of interest in our program. all of Ontario's EDs are discussing how to mobilize this type of technology for their own, suiting their own setting, their own situation. We have also talked to pediatric emergency departments across the Canada to share what we're doing, and everyone is looking at virtual care, perhaps not exactly the same model, but adopting whatever works for their particular region. So, you know, another possibility when we move into the future is that every day in our emergency department, we provide telephone consultation to regional community emergency departments throughout Eastern Ontario, Western Quebec, and even in the north. And so having a video link to that place and being able to do this with a visual context for how the patient is doing would really provide an amazing adjuvant to how those consultations occur. So we have lots of ideas. I'm sure you can hear that we're quite excited about it. I think that there's lots of opportunity for improving the care of patients in many, many different ways. And so, you know, I think in general, just to finish off, that the pandemic has really pushed medical practices to be nimble, to quickly adapt to our new context, to use technology to reach our patients. And our emergency department has joined that journey, and we're really excited about what the future may hold. So I thank you for your attention, and we've left lots of time for questions. So I think we can open the floor for questions, Paula.
Great. There's several that have come through.
Okay, great.
The first is Zoom integrated into the EPIC scheduling? This person said she might have missed when you discussed that.
Yeah, so EPIC currently at CHEO has a Zoom for Healthcare secure platform integrated into it. So it is sort of the higher level version of Zoom, and our clinics are using it, and our emergers using it.
As a follow-up, are there any privacy concerns either by the virtual communication or the fact that people are being seen in their homes? Are there any privacy concerns with the Zoom application?
So that's an interesting question, right? Certainly, when we first started this, our patients, our families questioned about our use of Zoom. And so we do try to reassure them that it is as secure a platform as we can manage on our EMR. So there's two layers there. There's the Zoom layer as well as the EPIC layer. You know, seeing somebody in their own home is always an interesting experience. Sometimes we can, you know, help them figure out what is needed. But the parents agree that, you know, this is where they want to be. They pick the room that they want to be seen at. They, you know, show us the parts of the child that are relevant to our exam. So they have agreed to that portion of this virtual contract. Sarah?
Yeah, I would add that we're certainly sensitive to that. And so we do verbally discuss the limitations and the potential privacy concerns around virtual care with every patient and receive verbal consent prior to initiating the visit. So that is, I think that's an important part for people who are considering this and building this, that, you know, we're using a secure encrypted platform, but there's always, you know, it's different than seeing a patient in real life in a room in an emergency department with the door closed. And so I think it's really important to be upfront about that and to acknowledge that and to have that candid discussion around privacy prior to initiating the visit for sure.
Makes sense. You mentioned the nurse, there was a nurse who followed up with all those who have been seen through the virtual ED. Are patients ever given a second virtual appointment if perhaps their issues weren't resolving, or are they then asked to come in?
Yeah, I mean, I think that there's a number of different, you know, we knew that when we designed this program that there were going to be, and at the beginning we didn't know what the percentage was going to be, but there's going to be a group of patients for which you're going to be able to do A to Z through the virtual care platform. And then there's going to be a smaller percentage of patients, and we know now it's around 22 to 25%, who are actually then going to have to come into emergency either for an investigation or a real in-person assessment in order to ensure that the diagnosis is correct. So I think what you're asking about is how do we organize follow-up? So I think that there's a few things that we can do. Sometimes that means we really want them to see their primary care physician. Sometimes it means that we might get our follow-up nurse to call them the following day if there's a result that needs to be followed up on, or just with a sort of over the phone, how is the child doing kind of thing. We have not, to my knowledge, organized a follow-up virtual care visit, but certainly I think that there are some occasions where the child may be seen the following day and the parent knows that that's an option for follow-up, but there's no mechanism by which that is automatically done. It would require the family to go through the process that we've outlined today. I think that that's appropriate. It's kind of similar to what we might do in real life, right? That if things aren't better, make another appointment and I'll see you again, kind of thing. So I think just like in real life, there's lots of different avenues to ensure that there's really tight follow-up for the child. And again, as Sandy pointed out, I think it's one of the key things is that the shared decision making in this model is really, it's important in real life. It's also important in virtual care. So having that really good discussion with the family, okay, we have to be upfront about what the limitations of virtual care are. And we need to then really make sure we have very good discharge instructions, that the family's very clear on what would necessitate returning to care, seeking further care, what the trajectory of the illness is supposed to be, and if things are not going the way we expect, this is what I want you to do, and let me help you to facilitate that.
Great. Yeah, we also do a lot of reassurance, right? Not only can they re-register for virtual care, but our bricks and mortar emerge is open 24/7, and we do a lot of reassurance, whether we are sending them to the hospital or not, that should they require an assessment, that we are open, that we are safe, and that they can come at any time.
Yeah, I mean, it's interesting. I just had a patient recently whose child had an issue that, was actually concerning, like probably needed to see a consultant. And they live far away. They live more than an hour from Ottawa. So I said, just how about we pause? I'm going to call the consultant. Let me see what we can organize and I'll phone you back, which I did, which I was able to get in touch with the consultant. We made a good plan for the patient. They wanted to be seen, that the consultant would like to see that patient on that same evening, phone the family and explain to them exactly what would happen. The mom had an underlying medical condition for which, she was a bit concerned about being exposed in the hospital. Right. So we could have a really good discussion about exactly as Sandy says, that reassurance around, first of all, a low level of disease in our community right now and a very safe environment when you come into the hospital because of all of the measures that we put into place. But then, it's not a wasted visit. They know for sure we need to go today. They feel very reassured. It's tight. The plan is there. It's all organized. The patient is put into our electronic health record as an expected patient with a plan around exactly what should happen. And so hopefully it really streamlines it for families as well.
Another question kind of related, were there any specific training that you had to undergo in order to mitigate any medical legal risks? And do you have any recommendations in that regard?
That's interesting. I mean, we did as a group have discussions around what we called sort of clinical considerations to try and standardize our approach to some common issues. So, how do we organize, for example, if a patient has urinary symptoms, for them to come and have a urine test done, and how are we going to do the follow-up for that? We decided that if there was a patient that needs an x-ray that may well have a finding that requires a cast or a splint, that they actually would need to be seen by the emergency physician so that we eliminate a second visit. We did as a group go through many common presenting complaints to sort of agree on what our approach was standardized. We also were very upfront about the fact that
looks like Sarah has frozen.
Yeah, so we did sort of have multiple discussions, different teams. We do have an IS manager that is managing the clinic appointments as well. And so for them, they also standardized what that would look like from a clinic, and we adopted that for emergency. Of course, in our emergency environment, these are patients that we don't know and that they're new to us. And so we really had to look at our medical legal risk and ensure that we were
The
not
clinical piece, yeah.
having trouble. Yeah. Sorry, Sarah, you froze there for a second.
Oh, I'm sorry. I'm sorry. I don't know where I froze, but all that to say is if you're planning this with your own group, I do think that there needs to be a piece, a group of clinicians who are in charge of addressing the clinical considerations and how you're going to standardize, how you're going to ensure that you're still offering a very high standard of care, and really being upfront about what the limitations of virtual care are, even though it's amazing, but it can't do everything. So we need to be really upfront about that.
So Jennifer also asks, comments that they're in the process in her organization of implementing EPIC for EMR, and wondered about trialing a pilot project in their emerge department. Would you be willing to share your IT knowledge, forms, triage, etc.?
Yeah, I mean, we're happy to have this disseminated to whoever would like to use it. We're happy to add our own voice to sort of help we work through the process if that's required. Now, I will caution you that learning EPIC in and of itself is a fairly steep learning curve. We went through that a few years ago, and we're quite comfortable with it now. But it took a while for us to sort of get back to regular business on the new EMR. So adding two things together, I mean, maybe it's possible to learn the two together, but I would just be cautious about how much you want to do and what time you have to do it.
That's fair.
Yeah, that's fair.
Yeah.
You commented before, Sarah, or perhaps it was Sandy, on the change management aspects of this. This question relates to it. Were the physicians receptive to practicing emergency medicine on the virtual platform? Any troubles with staffing the virtual hours? And are nurse practitioners involved as well?
Yeah, we've decided that we would start just with pediatric emergency physicians, so staff physicians, no trainees, no allied health, just the PEM full-time pediatric emerge staff, just because it's so new, and you just don't know what clinically is going to be, are there going to be the issues. So that's what we decided to start with. I think, and Sandy can speak to this more, I think that there were definitely members who were less comfortable, a little bit more nervous about what this was going to look like, because as we mentioned, you don't have any training in this. Nobody's really doing this. It's very novel. So, but I do feel like once you've done it a few times, you realize that there's many things that you can do to adapt and to adopt during the virtual care visit that allow you to do a very good assessment of the patient. And if you're not able to, then the patient needs to come into emerge. And so that, I'd say that my impression is the anxiety and the resistance has really decreased. We are staffing based on had a decrease in staffing in the bricks and mortar emerge because of those decreased volumes that we shared earlier. And so at present, that's fine. But when volumes increase in the bricks and mortar emerge, we're going to have to be creative about how to staff this new entity. And perhaps Sandy can speak to that.
Yeah, so I'll add to that we had a couple of physicians for their own personal or medical concerns were unable to sort of come into what could be a high COVID environment. And so this really helped them to provide clinical care in a different model, and they were able to work from home. So there is that thought as well. And we've had a couple of consultations from the UK from physicians and teams that are, again, where some physicians are unable to work, what do they do? And so virtual care helps with that. Yeah, as we move forward with, as the numbers start to climb a little bit, we are looking at partnering up with our pediatric colleagues and our community colleagues to see what their interest is, to continue on our virtual care platform. We're trying to be very inventive and again, innovate this in a new way to try to bring that, maybe less into the appointment model and more into, what actually looks like in our emergency department. Can an emergency doctor working in the physical environment see a virtual care patient? So there's lots of different ways that we can think about it. Now, I'm not an IS person, so a lot of that will depend on our teams and what they're able to do with the programming. But there's lots of ideas floating out there as to what might be possible.
Well, that's exciting.
I think the future, it's sort of like our pilots finish. We've got the proof of concept. This works. And so now it becomes, how does this become part of just one of the options for care, and how do we integrate it and how do we scale it? And so that's going to be sort of phase 2. Yeah.
Right. And sustain it. Yeah.
Yeah, exactly. Yeah.
Were there any concerns that the pre-questions that families had to fill out in order to get the virtual appointment would take too long at a time when it's a potential emergency and time is critical?
Well, yeah, I mean, no, because if time is critical, the patient needs to come into the real emerge.
Right.
Okay, so that's the, we've had people sort of raise, well, what about like an allergic reaction? Well, that is not an appropriate visit for
Right.
virtual care, because you may get an appointment a few hours from when you ask for one, right? Because it's the next available appointment. And so that it's very important for families to know that this is not an appropriate service for an emergent issue, right? So I think in answer to the question, going through the process, it's actually just a few minutes. It's not onerous. But I would also say to that question that I think we need to be upfront about the fact that this is not an appropriate venue for a problem that is potentially life-threatening.
Right.
Or is emergent in that sense, because that's a patient that you should do what you would do normally, which is call 911 and then come into the main emerge where we're able to do what we need to do.
And are there communications planned to sort of socialize that among the parent population, family population in Ottawa to help people better understand how to use, or did your pilot suggest that communications wasn't necessary?
Well, when we did initially start on May the 4th, there was a lot of press locally around this. And so, that I think we did try and really stress that, the first step is to figure out if this is right for the problem that your child has, right? We really, Sandy can correct me, but I don't think we've run into any issue where we thought, the child was very ill and the parent had sort of misinterpreted that. Like I think it's pretty clear. It seems to be working well, in other words.
Good.
Yeah.
Good.
Yeah, we have had a couple of cases where the doctor really wanted the child to be assessed in the emergency, maybe has some tests. And we hear anecdotally that the parents are still very reluctant. So there's a lot of time that we spend reassuring parents that they need to go to emergency, that is the right thing to do, and that it is a safe environment. So it's a funny thing, prior to the pandemic, we were trying again to sort of ensure that the families were seeing their family doctors, getting care in their community, and trying to sort of limit the low acuity visits to us. And now we are doing the same thing, but in a very different way, right? And we're sorting a little bit and more for the concerns that families have about the pandemic and what it means to go to a hospital.
Right. A slight follow-up to that, somebody wanted to clarify the intake or screening results in booking the next available virtual appointment. And the clarification that they're looking for is, are they not seen or scheduled based on priority?
No, this requires a bit of a frame shift, because this is not a service where there's a triage, right? So we've eliminated that triage, that sort that happens in the bricks and mortar emerge by an experienced nurse who's able to assign a C-test category and decide the urgency of the problem. So that's eliminated. So this is self-referral they do an intake form, and that's how it's next available appointment, because we really do not have a mechanism by which we can perform a triage assessment. Yeah.
Ah, yes.
It's interesting. It's an interesting concept, but yeah, we couldn't think of a way that that actually would be done accurately. So it's a different model for sure.
Okay. How applicable or what might need to be adapted to this model to implement it in a medium-sized community hospital with one on-call pediatrician at any given time? And what are the obstacles you might foresee for this non-tertiary care pediatric program?
So would this be a model where the emergency doctors would be using it, or a model for when the emergency doctor wants the pediatrician to come in to see the patient?
I will suggest that Madin, who posed the question, may want to clarify, and we can move on to a different question until we hear back from Madin.
Okay.
Are there evidence-based guidelines already existing for telemedicine in the emerge setting? What can be done, what cannot or should not be done?
Not that we're aware of. There's definitely guidelines from the CPSO for telemedicine that they're from a few years back. And the Royal College has some guidelines around telemedicine and virtual care. I mean, I think one of the tenets is something we've already discussed, which is maintaining the standard of care. So I think that that's really the lens that we need to use for this. And that's one of the reasons, you know, for example, in our QA process, we are collecting data on prescription of antibiotics, right? Because that's one of the worries, that if you look at some of the evidence that's come out of the States where they're doing a little bit more virtual care and have a bit more experience, that's one of the concerns with this model, that there's a lot of prescriptions for antibiotics when perhaps the physical examination is really not complete. And so that's something we're going to be being very careful about in terms of making sure that we're not falling into that trap where that's occurring. I don't think we're seeing that yet, but it's something that we're going to be really following closely, because that's a major outcome that we want to ensure is not a sort of a side effect of doing virtual care. So important to have a really good QA process in place and just make sure about it. I think our overarching goal is just to maintain the standard of care and not cut corners. Yeah.
Fair.
Yeah, relating to standard of care, we're also tracking not only how many patients are being sent from virtual care to the emergency, but also how many parents arrive with their children within 72 hours after having a virtual care appointment. You know, as an indication of, you know, did we miss something, or has something deteriorated to a point where, you know, they should have probably been seen in emergency in the first place. And we haven't really come across any particular issues to date. It's not meant to say that it won't happen, but to date, we haven't had any particular problems where something was significantly missed on virtual care.
Great. From a health equity perspective, have you dealt with socioeconomic, language, and other barriers to virtual visits?
Yeah, so we explored that. You know, so we do offer this virtual care at CHEO in a bilingual, so for French and English. We do have a significant number of bilingual physicians. So as we staff it with our emergency physicians, we are able to offer that service. For other languages, it becomes more problematic. You know, how do you book a translator? At what time can they come? You know, how do you get them online at the same time to provide the right care at the right time? And we couldn't find a good way to do that. So we are fully cognizant that, you know, some populations are marginalized with this virtual care. And we hope that with that, we can continue to just insist that they come into our emergency where we can actually book translators and have them present to help us with their care.
Makes sense.
Yeah, and I mean, I think I mean, the technology piece is the other piece, right? So we know that you need a fairly good cell access or Wi-Fi access. You need a device that has a webcam. You need to be able to download and to be able to know how to do that, downloading the Zoom, etc. So there are some barriers for sure, and I think that over time we are going to have to, when we go through, if this indeed continues, and we're going to have to try and optimize and try and have some creative solutions to, how do we ensure that there's as good an access to as many populations as possible, so that that sort of health equity issue is addressed as best as we can. But yeah, certainly I think those are very good points.
So I haven't heard back from Madin yet, but apart from that, the last question here relates to whom should someone direct a email to get more information about implementing this
Yeah,
in their setting.
Either of us is fine, I think.
Okay.
Yeah, we're happy. We've had lots of friends. We have lots of friends now across the world who are reaching out. It's really, I mean, the generativity that is occurring during the pandemic in terms of sharing and the innovation is great. So we're happy to hear from anybody. Yeah.
And just so you know, there's a number of positive comments coming through in the chat, in the question box. Folks are very excited about the webinar and very pleased with your initiative, and I think you've turned on some juices for others to consider it in their settings.
Thank you. So I would say that the best thing that I think I get from this virtual care platform is just how appreciative and how happy the families are to be able to access care. I've been working in an emergency department for a very long time. I'm not going to tell you how long. But you know, the level of engagement from our families is tremendous.
I would agree. Yeah.
Wonderful.
Yeah.
So oh, go ahead. No, go ahead, Sarah.
Oh no, well, I just thank you so much, and we're just hoping everyone stays safe.
Yes, absolutely.
And I want to thank Alicia too. I know she didn't want to come on video camera, but we want to thank you for participating in this discussion.
Yeah, no problem. Thank you. I'm an absolute advocate, and keep it up.
Thanks, Alicia.
A champion in your back pockets there.
Yes.
Well,
so
I
thank you.
I don't want to come and see you too soon.
Yeah.
So I just want to thank you, Sarah, Alicia, and Sandy, for sharing your time and expertise with us. Thank you to all of our attendees for spending this time with us, and we hope you depart with some practical ideas. Typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. However, during the COVID pandemic, we've been offering some special editions of our knowledge sharing opportunities, and these may fall outside our typical webinar spots. As well, we usually take a break from hosting Spark Live during July and August, but amidst COVID, we'll continue to offer timely and relevant content periodically through the summer months. And in fact, we have several sessions currently in development for July and August. The next confirmed webinar is scheduled for August 12th at 11 a.m. Eastern. And at that time, we'll be hearing from colleagues from PolicyWise and Alberta Health Services, as well as from the US, who will be presenting on applying principles of disaster psychosocial recovery to the COVID-19 response in healthcare settings and systems. And while our webinars may not be scheduled each week over the summer, you can still stay up to date on all of our activities and events by signing up for Children's Healthcare Canada's Spark newsletter and following us on Twitter at ChildHealthCan. It's always great if you can watch live, as your questions and comments enrich the discussion, but if you can't, the sessions are all recorded and we make them recordings available after the fact on our Knowledge Exchange network. So thank you again for joining us today. Thanks to CHEO for supporting our webinar program, and hopefully we'll see many of you back here in July. Bye, everyone.